This is Dr. Julie Pongrac. I'm representing the CIHR Canadian HIV Trials Network, also known as the CTN. The CTN has been in existence for more than 30 years. It began as a response to the early days of the HIV pandemic with funding from the Canadian Institute for Health Research, the CIHR. At that time, there were so many gaps in our knowledge around what it meant to live with HIV and AIDS. As the name indicates, it is a trials network with a focus on conducting clinical trials as a means of bringing innovative treatments to those living with HIV. Not long after it got off the ground, the CTN developed a postdoctoral fellowship program to ensure that sufficient infectious disease research specialists were being trained to fill the unmet needs. After 30 years, the CTN Postdoctoral Fellowship Program has become a world-recognized training program that integrates training that focuses on the unique needs of the community, those living with HIV and AIDS that the trials aim to support, with training that encourages the postdoc's scientific development. My role with the organization is in administering this program with an eye on the past and the future. Today, we will be hearing from several CTN postdoctoral fellows after a year of training as they describe what makes their training stand out. Let me introduce the first of these trainees. Dr. Alice Zhabokritsky is working with people who are aging with HIV and looking to discover what this means with respect to doing so in a healthy way. People aging with HIV are able to do so because of their use of antiretroviral therapy, also known as ART treatment, that allows them to maintain a negligible viral load. When they experience conditions that arise with aging that also require medication, the additional medications can lead to multiple drug interactions. For this reason, Dr. Zhabokritsky is focused on the issue of polypharmacy in people living with HIV. Let's hear what she has to say about her training with the CTN.
This past year as a CTN Postdoctoral Fellow has given me so many amazing opportunities, especially being mentored by the CTN National Co-Director, Dr. Sharon Walmsley, and working alongside with her on the Change HIV study, which is the first Canadian cohort of people living with HIV over the age of 65. And something that she's taught me from the very beginning was that the best questions for clinical research come from the affected population. And so that has really set the stage for my training and how I've approached this work. Specifically, I've made it a priority to engage with people as they age with HIV in various capacities. As a researcher, I've participated on the Study Community Advisory Board, participated in community workshops, and as a healthcare provider, this has really been through my clinical practice and engaging folks that way. And this has given me the insight that allowed me to understand what is important for people as they're aging with HIV and figure out how we can best measure this healthy aging process. For example, one theme that has emerged through this work has been pill burden that people are experiencing as they're aging, and addressing the multiple medical side effects that they experience related to medication has become a priority and led me to start thinking of how I can best address this, always kind of reflecting back on the people that this is actually affecting.
Another of the CTN postdoctoral fellows, Dr. Joshua Edwards, is working on understanding how to engage vulnerable populations in the use of prophylactics for the prevention of sexually transmitted bacterial infections, which includes in populations of individuals living with HIV. There are various pharmacological interventions with proven effectiveness as prophylactics that can be taken either pre-exposure, also known as PrEP, or post-exposure, known as PEP. However, creating meaningful practices requires consideration of how to engage populations most at risk and their effective uses. Let's listen to what Dr. Edwards has to tell us about his training with the CTN.
I have spent an amazing past year with the privilege of working with Dr. Troy Grennan, who is a former CTN postdoctoral fellow himself and the current co-lead of the Co-Infections and Related Conditions Committee at CTN. I work with Troy on the DISCO trial, which, as Julie mentioned, is devoted to investigating doxycycline as pre-exposure and post-exposure prophylaxis, including in men living with HIV for bacterial sexually transmitted infections. Troy and I also have some other studies funded by the CTN on human papillomavirus, or HPV. So I think one of the things that's been really exciting about this first year as a postdoctoral fellow is that I've got to work with Troy. Both Troy and I have in common that we started working in our community before we advanced to kind of like research, before Troy went to medical school and became an MD and an infectious disease doctor. We both worked frontline at sexual health clinics. And I think that we took away from that and have really a shared vision of rooting, working with our community, research that's rooted in participation, and really viewing research and including a clinical trial is something that you can conduct with the community as collaborators and partners, and as full voices in this research. So I think the genesis of all of that stuff together is that we feel like it's really important that we continue to explore new ideas in health research and in treatment. Existing interventions for sexually transmitted and bloodborne infections haven't necessarily stopped new transmissions. We've increased testing opportunities and all that good stuff, but just really felt like we needed to work with our community to look at some new options, hence the PEP and PrEP bacterial STI focus. I also did just want to take a moment and share that one of the things that I have learned over the past year is just how much I have to learn and continue to learn from community members, and especially those members who serve on the Community Advisory Committee and Scientific Review Committees for the CTN. I can tell you that the feedback that those individuals have given myself and others on various study proposals, protocols, etc., is really just second to none. It's rigorous, it's amazing, and it's helpful. And it really, does consistently remind us to keep our community like front and center in this work. So special shout out to the community members who are also participating with the CTN on these committees.
The importance of social engagement and support can never be underestimated in ensuring that care reaches the populations most at risk of HIV infections. HIV has disproportionately affected our Indigenous communities across Canada. Our next fellow, Dr. Cara Spence, is working with Indigenous women living with HIV in Saskatoon, developing an HIV database and standards for clinical care. Let's hear Dr. Spence speak to the necessity of peer support in ensuring the success of this work.
Working with peer mentors is so valuable. I learned just as much about myself working with the peers as I do about them. And part of this work is recognizing my role. So my role is to help support the research or support the recommendations for clinical practice, but guided by and led by the peers, the Indigenous leaders. Also working with the peers or working with Indigenous leadership has so much to offer mainstream health system or mainstream populations. In particular, we have a project that's land-based healing, teaching, and learning. And the intrinsic wisdom that's embodied within that project and within those leaders, there's an opportunity for Indigenous leaders to also inform the mainstream way of approaching health and wellness, that it's not external to us, that health and well-being comes from within us, and true healing is a personal journey. So, working with a Western clinical model with Indigenous communities, it's really seeing how we can work together, how we need to work together, and where we complement each other and where we can learn from each other. And that learning certainly goes both ways. And any opportunity you have to interact or to be taught, to learn from peers, from people living with HIV, with Indigenous leadership, is an opportunity for you to not only grow as a clinician or a researcher, but to recognize what you don't know and recognize what there is yet to know. As a non-Indigenous researcher, it's most important when working with Indigenous communities, Indigenous individuals, fellow humans, women, that there's a sense of connection and relations with each other, relation with the world around us, and that we're not othering each other or creating difference, and that we need to see how we're more alike than different. And that's where the truth and reconciliation happens, but also where healing happens, where we can come together. In research terms, that access is critical for true seeking of knowledge, for true expression of truth coming from the participants. And you can get to the heart of the matter if you're willing to listen and move outside the way you understand and see the world.
Within the CTN postdoctoral program, we also have fellows that study very specific issues of select groups within the larger population of people living with HIV. Dr. Lena Royston is focused on the global understanding and clinical management of a form of cancer called Kaposi Sarcoma that was prevalent in people living with HIV in the early years of the pandemic. This cancer is now appearing to be prevalent in a group of individuals living with HIV that are well managed with ART treatment, but also live with the herpes virus HHV-8. This secondary viral infection makes them particularly susceptible to this form of cancer. Let's hear what Dr. Royston has to say about her work and training experience.
There are actually many reports of unexpected cases of Kaposi Sarcoma in well-treated people living with HIV, both here in the HIV clinics of Montreal, but also in other countries around the world. Also, the clinical presentation is less aggressive than in other forms of Kaposi's. The typical skin lesions that occur are very concerning for patients because they recall the strong stigma of the darkest days of the AIDS epidemic. In addition, this form of the disease is puzzling in terms of clinical management because the antiretroviral treatment is already introduced. The notion of stigma felt by people with this form of the disease is really at the center of this research project. And I'm using both my experience as a physician and a researcher to try to reduce it. Altogether, we hope that this study will lead to new therapeutic or even preventive strategies in order to avoid the re-emergence of Kaposi in people who already suffer from discrimination due to the HIV status itself.
There are those professionals in the CTN that also work on ensuring the populations represented in any given clinical trial truly reflect that population under study and will be meaningful for the larger population of people living with HIV. Achieving that goal requires that diversity within the population be considered in the design of any trial. Dr. Serge Vicente, our next fellow, is a statistician that utilizes a unique skill set in the pursuit of getting that balance right. Let's listen to Dr. Vicente tell us how CTN postdoctoral training helped him understand how to frame this question with respect to HIV trials.
I'm Serge Vicente, and I'm currently a second-year CTN Postdoctoral Fellow and also a statistician. So during my PhD, I had the opportunity to work with an unexplored topic in statistics, diversity in the context of sampling. And also along with my PhD and since 2017, I'm also working as a statistician and a research trainee at the Research Institute of McGill University Health Centre, Montreal, Canada. And this particular collaboration marked my first contact with HIV research and also alerted me that diversity is also a serious issue in HIV research. For example, we know that although women comprise nearly half of people living with HIV, but they represent only 19% of participants in antiretroviral therapy studies, 38% in vaccination studies, and 11% in cure studies. And furthermore, most HIV trials insufficiently address sex and gender, level of available adherence support, injection, drug use, and co-infections. And also racial and ethnic minorities also face barriers to participate in HIV trials. So thanks to my CTN Postdoctoral Fellowship, I'm currently expanding my PhD work in diversity to HIV research. I funded my own research project supported by a CTN grant, which aims to develop an index to quantify whether the samples included in HIV-specific research activities represent truly the target population diversity using demographic and social determinants of health variables. In addition, attending the specific CTN activities at the spring and fall meetings allowed me to establish contacts with CTN members and researchers, since they will be part of my research project as engaged stakeholders. The Community Advisory Committee and Scientific Review Committee reviews represent then a good opportunity to present my research to renowned researchers, obtain a valuable feedback, and capture their interest in participating in my project.
You have now heard what special opportunities the Canadian HIV Trials Network postdoctoral fellows value during their training in their efforts to become highly skilled health researchers. They are the next generation of professionals that will be treating and caring for people living with HIV and others with sexually transmitted bloodborne illnesses. We know the future will present a variety of different training challenges, but we aim to continue to meet those challenges with innovation, as has been the tradition of the CTN Postdoctoral Fellowship Program. Thank you very much for your attention.